Hi, this is John Pagel, and again, I'm going to discuss some of the newer agents that were presented at the American Society of Hematology meeting in San Diego in December of 2016. These are newer agents in development and for therapy for patients with chronic lymphocytic leukemia, or CLL. And in particular, I'm going to tell you a little about a new approach of using maintenance therapy or ongoing therapy after someone has achieved a remission for patients who have, in this case, upfront treatment for their chronic lymphocytic leukemia. In particular, a study led by the German CLL study group and presented by Dr. Fink explored the use of a drug we call an immunomodulatory drug called lenalidomide or Revlimid as maintenance following first-line therapy, and in particular those therapies were what we call chemoimmunotherapies. Those are combination chemotherapy regimens with antibody-based treatment, and in particular in this trial it used either upfront as first-line treatment in fit patients the use of either fludarabine, Cytoxan, and Rituxan, or primarily bendamustine and rituximab. And then once patients achieved a remission, with those who are high risk, they were either randomized to get lenalidomide or Revlimid, same drug, delivered orally, or they were randomized to a placebo. There was a ramp-up schedule in the dosing of the Revlimid. It was a very well-designed trial. There were about 60 patients who ended up getting the lenalidomide who were described, 30 in the placebo group, so a randomization of 2-to-1. We know that many of these patients, if not really all of them, who were able to go into this trial had extremely high-risk disease. And in particular, what we found is that despite the fact that many of patients who could get a complete remission from their upfront treatment, the lenalidomide actually was something they could do very well with as a maintenance approach as they moved forward. And in fact, what was seen was that the patients who were randomized to the lenalidomide treatment, and in particular those, again, these are patients with very high risk, had a reduction in their risk for relapse, progression, or death of about 80% versus those who were randomized to the placebo. A significant improvement in that regard, and in particular also led to an improvement for those patients who had an ability to eliminate minimal residual disease. Nonetheless, I think it's very important to note two important factors. One is that there were side effects associated with those who were randomized to get the treatment or the Revlimid. We do know that about a third to almost a half of patients actually had to discontinue the Revlimid because of an adverse reaction. Those were low blood counts in many patients. They might have been some GI or gastrointestinal disturbance in many. A fair number of infections were seen, and some rashes or skin disorders. Again, relatively mild, but all things that were seen in the patients who received the lenalidomide as opposed to those who did not receive the drug or those who did get the placebo. And then the second factor to note is that overall survival was no different in each of these two groups. That means that in the high-risk patients who had achieved a remission and then were randomized to get lenalidomide or a placebo, there was no difference in how long they lived, albeit the follow-up on these patients is relatively short. It does suggest that this might be a reasonable strategy in patients with very high-risk disease, giving them lenalidomide maintenance therapy, and we need to follow people for a lot longer if we're going to see that it has an impact in their survival.